So yeah, I'm Fabian. I'm a second-year radiology resident here at Yale, and I'll be talking about interventional radiology in Tanzania. Like Frank mentioned earlier, there are about 50 to 60 radiologists in Tanzania right now. For intervention, we have even more accurate numbers, and the number is 0, unfortunately. There's not a single interventional radiologist in the whole nation. So that's as if there was not a single interventional radiologist in California, which is pretty hard to imagine. So how do you assess interventional radiology in a place with no interventional radiology? I don't know if there's a perfect way, but this is what we did. So we assessed facilities and equipment, then tried to identify key personnel, assessed the case spectrum and needs, and then tried to develop a long-term plan for interventional radiology in Tanzania. As for the facilities, like Frank said, there's a number of hospitals which are sort of all on the same campus. So one is M&H. Here there are 4 ultrasound units. There's a C-arm fluoro, there's an MRI, a 128 slice CT, which you can see here on this image. At Muhimbili Orthopedic Institute, there are 2 fluoro units, 2 ultrasound units, and they're planning to build an angio suite over the next couple of years. Next door at the Cardiac Institute, there's an biplan angio suite, which is already in use, which you see depicted here. And then there's MUHAS, which Ken mentioned earlier. It's the new teaching hospital just outside of town. It's a state-of-the-art hospital. Actually just opened last month. So here they basically have all state-of-the-art facilities, including ultrasound, fluoro, MRI, 64-slice CT, which we can see here. And they have an angio room, but there's no equipment in the room yet. So it's, at this point, it's just a sign, but they're planning to equip it over the next 1 to 2 years. As for key personnel, like I said, there's no specialty training and no IR faculty or trainees in Tanzania at this point. However, there's a large residency program, as we heard. So this year alone, there's 25 new residents. And among those residents, there are some which are very interested in interventional radiology. And also among faculty, there's excitement about IR, and they want to learn about it. But at this point, the only ones actually doing procedures that are somewhat related to interventional radiology are the pathologists who are performing fine needle aspirations of lung, liver, etc. And there has been a visiting team from Kenya consisting of 1 interventional radiologist and an IR technician who came to Tanzania twice, I think 2 times for a weekend basically, and did a bunch of procedures. As for the case spectrum and needs, so the need is huge. Basically, IR could provide useful procedures for literally every department in the hospital. So I just wanted to highlight a few patient groups that would really benefit from this. One is pediatric patients with hemangioma. So they sometimes have huge lesions. They used to be referred to India for treatment. This costs about $30,000 per patient. And the new administration is no longer doing that. So there's been some political changes. They're no longer sending kids to India for treatment. So now they're in Tanzania, and there's no one that can do sclerotherapy to treat them. So they would benefit immediately. Also, like any general surgery or medicine patient with, for example, perforated appendicitis with a deep pelvic abscess, currently needs to undergo laparotomy and a surgical washout. Instead, IR could just put a drain in, which is a lot less invasive. Then, of course, there's a huge trauma population in Dar es Salaam. One thing IR could provide, for example, splenic artery embolization instead of doing splenectomy. Then neurology and neurosurgery patients obviously would benefit from clot retrieval or coiling of intracranial aneurysms, which currently no one can do in Tanzania. And then oncology patients would benefit from simple things just as corneal biopsy. So currently there's only FNA. So even just bringing corneal biopsy there would be amazing. And then, of course, going forward, ablation and chemoembolization of tumors would be very beneficial. Now coming to the last point, development of a long-term plan for interventional radiology in Tanzania. So this is how we thought of it. There's 3 main aspects. One is training of residents. The other is training of nurses and technicians. And the last is facilities and equipment. And I think that all 3 are equally important. You cannot do one without the other. As for training of nurses and technicians, that's really essential. As we know, you cannot run an IR room without having trained nurses and technicians there. You can't do it by yourself. Also, facilities and equipment, of course, need to be adequate. But I'm going to speak mostly about the training of residents now. So here's our plan. We're hoping to send 10 IR faculty there per year for at least 3 years, and not just from Yale, but from all over the US. Also, we're working on providing study resources to the residents in Tanzania. Like Ken already mentioned, one part of that is a streaming of lectures to Tanzania. So we're hoping to, going forward, also stream more IR lectures to Tanzania. Then another aspect is going to be providing IR observerships and research opportunities for Tanzanian residents who want to come to the US in order to be exposed to, just what a Western IR department looks like. And the overarching goal to sort of tie everything together is going to be establishment of a competency-based IR curriculum. And we think this is really the way to guarantee a self-sustaining IR training program in Tanzania. Now, as for the practical training schedule, this is sort of just a rough outline over the next 3 years, what we hope to accomplish. So now, starting over the next year, we want to provide procedures that can be done immediately, where we basically already have all the imaging facilities in place. Then the year after, move on to more advanced percutaneous procedures and some basic vascular procedures. And then in 2020, we hope to accomplish or start doing some interventional oncology and neurointerventional procedures. So just a couple of examples here. Phase 1 would include core needle biopsy, sclerotherapy for hemangioma, as I mentioned, fallopian tube recanalization, aspiration and drainage of abscesses, cholecystostomy tube placement, nephrostomies, and arthrograms. Then in 2019, we hope to provide gastrostomies, jejunostomies, central lines, IVC filters, and some basic diagnostic angiograms. And then by 2020, we hope to provide GI bleed embolization, traumatic hemorrhage embolization, thrombolysis for PE, clot retrieval and stroke, coiling of intracranial aneurysms, uterine artery embolization, and then chemoembolization for liver tumors, for example. The good news is that some of these procedures are already happening right now. So while we were there, we were doing CT-guided biopsies. So this is Frank, Ken, and I with 3 of the Tanzanian residents who want to go into intervention radiology. Aza over here, Ivan, and Eric. And Eric is holding a CT biopsy grid, which we made from chicken wire while we were there because they didn't have a biopsy grid, and it worked really well. Here you have the same 3 residents performing a nephrostomy tube placement under a guidance of the team that was visiting from Kenya, and that also provided the tube. And Ivan, by the way, is from neighboring Rwanda, and he came to Tanzania specifically because he was hoping that there he would have a higher chance of learning about interventional radiology. And here, this is the interventional radiologist from Kenya performing sclerotherapy in the operating room. And as you can see, there's a huge interest. Everyone wants to learn about IR, and people are excited about it. Now, if you're an intervention radiologist, this is what the schedule would look like. So you fly there, someone picks you up at the airport, shows you where you live, gives you a little orientation around the hospital, and introduces you to the people you'll be working with. And then the regular Monday to Friday schedule would consist of morning rounds with a discussion of the planned procedures for the day. Then, of course, doing as many cases as possible, and doing resident teaching while doing the cases. And if there's time in between cases, you could give some lectures to the residents about intervention radiology. On the middle weekend, there would be time for a trip to Zanzibar, like Ken explained, or another destination of your choice. The second week would be exactly like the first week, just with morning rounds, cases, and resident teaching. And the last day would be reserved for a review of interesting cases and discussion of progress, accomplishments, and problems that occurred during this rotation. And then someone would take you back to the airport. In terms of financing, so Frank already mentioned some numbers. A round-trip ticket is around $1,000 to $1,200. Housing is around $75 a night. So if we want to send 10 groups per year, that's a bit over $20,000, and for 3 years, that's around $60,000 to $70,000. So it is a bit of money, but considering that this may help introduce a whole new specialty to a country, I think it's a fair price. And here are the avenues of funding this. So like Frank mentioned, Yale has been extremely generous, and they're helping with flight tickets and housing. Also, Professor Musser from from MNH in Tanzania has offered to provide housing and to pay for Tanzanian residents who want to come to the US for observerships. But if we want to recruit IR faculty from other institutions in the US, we cannot rely on their institutions being equally helpful. So we have to find other ways of funding, and two options would be applying for grants and donations. In conclusion, I believe that IR can become an important clinical specialty in Tanzania, and most relevant facilities are already available at this point, and all missing equipment can be obtained. So we're on the right track. Every IR tenure fellow from the US can have immediate impact. So if this is something you would consider, I really urge you to do it. First of all, you're going to have a great time. And second of all, you can really make a difference. And the residents that you train there are then going to go out to across the country and neighboring countries and teach other people. So it's really going to make a difference. But in order to have sustainable IR services and a self-sustaining residency program there, we need to develop a competency-based curriculum